From the classroom to the emergency room, OR and beyond, you're joining Trauma ICU Rounds with your host, Dr. Dennis Kim.
I'd like to welcome you back to Trauma ICU Rounds. I'm your host, Dr. Dennis Kim. I'm an associate professor of clinical surgery at the David Geffen School of Medicine at UCLA and a trauma surgeon and the medical director of the Trauma Surgical ICU at Harbor UCLA Medical Center in Torrance, California. This week, we welcomed our new class of interns here at Harbor UCLA, and for all of you who are starting out your residency training, welcome. I can still vividly remember the visceral mixed emotions of excitement, enthusiasm, anxiety, and insecurity of starting my surgical residency and thinking that it would be a lifetime before fellowship or my early career as an attending surgeon would begin. And almost 20 years later, it's really incredible to think about how quickly time just kind of flew by. With that said, in thinking about a topic for today's rounds, particularly for those of you who are starting your postgraduate training in the ICU, a not at all intimidating rotation, I thought that it would be timely to review how we assess patients for readiness for extubation or the approach to liberating our patients from the ventilator. As the main goal of mechanical ventilation is to ultimately not need mechanical ventilation, you can pretty much be assured that you will be asked daily whether or not your vented patient should be extubated and why or why not. So we have 4 key objectives for today's podcast, and by the end of rounds, you should be able to, number 1, understand the basic approach to assessing ventilated patients for readiness for extubation. Number 2, describe commonly used weaning parameters that may potentially, but not really, assist us in determining the likelihood of success or failure during a spontaneous breathing trial, or SBT. And we'll probably spend the most time discussing the Rapid Shallow Breathing Index, also known as the RSBI. Number 3, you should understand different methods for performing a weaning trial, or SBT, both regarding the optimal method, be it a TPES trial, intermittent mandatory ventilation, or CPAP/pressure support ventilation, as well as the optimal duration and frequency of an SBT. And finally, you should be able to discuss the considerations that should be addressed prior to actual physical removal of the artificial airway or endotracheal tube. Now, I do want to emphasize that today's rounds are meant to provide you with a broad overview of the approach and considerations that should be undertaken when thinking about liberating a patient from the ventilator. And in future rounds, we'll review and discuss other key topics surrounding discontinuing the vent, such as identifying and treating post-extubation stridor, whether or not and in whom we should consider extubating to high-flow nasal cannula or non-invasive ventilation, as well as the approach to and management strategies for difficult-to-wean patients. As we've discussed previously on rounds, mechanical ventilation offers essential ventilatory support while our patients recover from whatever disease process resulted in them being intubated. And although acute hypoxemic or hypercarbic respiratory failure are by far the most common indications for intubation and ventilatory support, other patients may be intubated in an effort to support a failing circulation, as in patients with acute cardiogenic shock or pump failure, or in patients with, say, severe systemic disease processes such as sepsis or septic shock, in whom we're attempting to balance oxygen supply and demand by augmenting O2 delivery or supply and decreasing the work of breathing or demand. Yet, invasive mechanical ventilation is associated with risks and complications above and beyond VILI, or ventilator-induced lung injury, as we've discussed on previous rounds. For example, every day that a patient remains intubated, they're at an increased risk for the development of a ventilator-associated pneumonia, or VAP, and that ranges from 1 to 3% per day, and is also contingent upon the duration of mechanical ventilation. And much like CAUTIs, CLAPSIs, HAPIs, C. diff, SSIs, and VTE, these were all considered never events. Further, even short durations of mechanical ventilation, particularly when patients are provided with full ventilatory support, as may occur when we administer a neuromuscular blockade and patients are placed on continuous mandatory ventilation, These scenarios are associated with diaphragmatic atrophy and weakness, also more formally known as ventilator-induced diaphragmatic dysfunction, and even brief periods of mechanical ventilation can result in diaphragmatic dysfunction. Also, and this probably should not come as a surprise, having a polyvinyl chloride tube rammed down your throat, it's not the most comfortable or pleasant experience in the world, and as such, parenteral analgesia plus or minus sedation are often used in an effort to maintain patient comfort. And the problem with this strategy is that it results in this precarious balancing act or vicious cycle whereby we want patients to be able to cooperate, communicate, and be comfortable while intubated and ventilated, yet we need to administer sedatives and analgesics or neurotoxins in order that our patients will tolerate being intubated on the vent. Further complicating the matter is that use of medications like benzodiazepines may confound neurologic assessments and potentially increase the risk for ICU delirium, encephalopathy, and in the long term may contribute to the development of PICS or the post-intensive care syndrome. Now, before we jump into Objective 1, or understanding the basic approach to assessing ventilated patients for readiness for extubation, I want to clarify some terminology specifically regarding the terms discontinuation, liberation, weaning, and extubation. Like everything in the world of mechanical ventilation, whether we're talking about modes of ventilation or discontinuing ventilation, academicians really like to go out of the way to make the verbiage and terminology super confusing. So when we say we're discontinuing ventilation, this implies, hopefully, permanent removal of the ventilator, whereas the term liberation has been defined as the ability to breathe without the assistance of the vent, as may occur when a patient, for example, performs a T-piece trial successfully or a pressure support ventilation trial successfully. Finally, the term weaning, this isn't something that we typically do, at least not in the trauma surgical ICU too often. This really refers to the gradual reduction of ventilator support and its replacement with spontaneous ventilation. And later, when we discuss objective number 3, the different modes of weaning someone from the ventilator or different ways of performing a spontaneous breathing trial, we'll go over some of the differences and nuances between a T-piece trial versus pressure support ventilation trial. But just to give you a bit of a heads up, when we think about weaning, let's say using a modality like pressure support ventilation, this would essentially involve placing a patient on pressure support ventilation once we think they're ready for a spontaneous breathing trial, and starting with an arbitrary number like, let's say, 18 centimeters of water, and maybe every 12 hours or twice a day reassessing the patient for the potential of decreasing that pressure support by 2 to 4 centimeters of water to the point where the patient is on minimal vent settings, at which point we would consider extubating the patient. This is really more of a historical interest. I think in the vast majority of ICUs worldwide these days, if a patient appears to be ready for a spontaneous breathing trial, that patient would be placed on pressure support ventilation with anywhere from 5 to 10 centimeters of water to help overcome resistance within the ventilator circuit, and by the 30-minute or 120-minute mark would be extubated, provided that they meet all criteria for physical removal of that artificial airway. So again, in terms of clarity, when we're talking about discontinuing mechanical ventilation on rounds, what we're talking about is both liberating a patient from the vent and extubating said patient, and as such, you may notice that I use these terms interchangeably. So when it comes to assessing our vented patients for readiness for extubation, we want to and must be systematic in our approach, and this is where the use of protocols, ideally non-physician-driven protocols, have really made a big difference in getting our patients off the ventilator. In a 1996 study by Dr. Wes Ely, published in the New England Journal of Medicine, 300 adult MICU and CCU patients were randomized to an intervention group which consisted of an RT-driven protocol involving daily screening, performance of SBTs, and reporting of the successful completion of a 2-hour SBT to the physician team, versus the control group or standard of care, in which decisions regarding the approach of weaning, timing of SBTs, and discontinuation of the vent were left entirely to the discretion of physicians. And in terms of the three main outcomes, both the time to wean, defined as the number of days from the time the patient had a successful screening test to actual discontinuation of mechanical ventilation, and the duration of mechanical ventilation were significantly shorter in the RT-driven protocol group by 2 and 1.5 days respectively, whereas overall length of stay in the ICU were similar between groups. Interestingly, in the study, the overall total costs of ICU patient care were about 25%, or an absolute $400,000 less in the intervention group. So what's the take home here? Well, the systematic or protocolized use of predictors of weaning produces better outcomes than the judgment of physicians alone. As a surgical critical care fellow at UCSD, we use what was known as a STEER protocol, which stands for Screen, Test, Exercise, Evaluate, and Report. And again, RTs and RNs are in a much better position to perform these protocols. And so we'll post a link to that in the show notes. So when it comes to the basic approach to figuring out, can I extubate my patient or not, there are really two big questions you need to ask yourself. And the first question is, can my patient breathe on their own without the ventilator, or with the absolute bare minimum support from the ventilator? In other words, can my patient be liberated from the vent? The second question is, can my patient breathe without the endotracheal tube, or can I safely extubate my patient? If the answer to both of these questions is yes, then immediate discontinuation mechanical ventilation should ensue. But in order to answer the first question, can my patient breathe on their own without the ventilator, we need to perform two key assessments. First, we need to assess our patient's readiness for an SBT, and we'll talk about how we make that determination in just a minute. Second, once placed on the SBT, we need to assess if our patient is tolerating the SBT, and we'll talk about some of the measurements that we use to do this when we discuss Objective 2 of today's rounds. In terms of answering the second big question, can my patient breathe without the tube, we'll get into this when we tackle Objective 4, and so let's now focus, at least for the time being, on readiness assessment. So readiness testing or assessment has two major purposes. The first is to identify patients who are ready to wean from mechanical ventilation. And this is important because, as we just said, physicians suck at determining when patients are ready to breathe independently. In fact, 50% of patients in one study who self-extubated didn't require reintubation. And the second major purpose of readiness testing is to identify patients who are not ready for weaning. And the whole purpose here is to protect them against the risks of premature weaning from the standpoint of exacerbating cardiovascular dysfunction, contributing to respiratory muscle fatigue, as well as potentially psychological distress. So for those who are deemed not ready for an SBT, we need to search for, identify, and reverse all possible ventilatory as well as non-ventilatory issues, and this should be an integral part of the ventilator discontinuation process. Now, what specific criteria should we look towards to say that, yes, our patient is ready to perform an SBT? An international consensus conference on weaning emphasized that the first weaning trial should be considered ideally within the first 24 hours or after the first 24 hours. And the most important criteria we want to look for is, number one, evidence for some reversal of the underlying cause for respiratory failure. And this is what I really always emphasize with all the house staff in the ICU. When we're thinking, can my patient potentially be extubated, or is my patient ready for an SBT, the first and foremost question to ask is, why was my patient intubated in the first place? And why is this important? Well, we see a lot of patients in the trauma bay who come in with a GCS less than 8. That may be because they have a severe TBI, but more often than not, it's because they're super intoxicated or under the influence of other illicit substances, and so they get intubated mainly for airway protection. Well, you can imagine once that patient sobers up or once they've metabolized whatever substance has resulted in their encephalopathy or altered mental status, provided that no complications have ensued like a major aspiration or some other systemic disease process, that patient should be ready to extubate. So we always must have a sense as to what resulted in this patient being intubated, and has that disease process, condition, or reason either resolved or is it currently being successfully treated? In addition to reversal of the process that resulted in intubation, other things that we want to look at, and again, starting systemically and using an anatomic approach, is what are the patient's current vital signs? Are they systemically doing well? And so a quick look up at the monitor. And again, I would encourage you at all steps of this assessment to please talk with your RTs and bedside RNs who really have a good sense as to what's going on with your patient. So starting with vitals, are they hemodynamically stable as defined by the absence of active myocardial ischemia or the absence of clinically significant hypotension? Again, this is not to say that patients who are receiving vasopressor therapy are not candidates for a spontaneous breathing trial or extubation, and one only needs to rotate or spend a little bit of time in the CCU to recognize that a lot of patients may actually be on inodilators or milrinone, and that is not a contraindication to being extubated. And again, this gets back to the reason patients were intubated and has that process been reversed. Another important vital sign to look at is temperature, and certainly if patients are coming in and were intubated for, let's say, septic shock, the ongoing presence of fevers with the potential to increase potential demand is something to consider as well. So starting from the top and making our way down from a neurologic status, we want to make sure that patients have a reasonably appropriate mental status. This is not to say that they need a GCS of 4.65, but ideally patients are somewhat cooperative and able to participate in care, especially when it comes to things like having them clear their secretions and participate in physiotherapy. We've already touched a little bit upon the cardiovascular status, but other criteria that you may see looks at things like heart rate or the absence of significant tachycardia. And then from a pulmonary system, and this is probably one of the most important, ensuring that they have adequate oxygenation indices. So whether you want to go with O2 sats, the PF ratio probably isn't that helpful, but here's where you're really kind of looking at a constellation of symptoms and signs. Are they having excessive work of breathing? And when you look at the ventilator, what sort of minimal vent settings are they on? And so typically our protocol here is an FiO2 of less than 40% or even better 30%. With minimal PEEP, anywhere from 5 to 8 centimeters of water, and then a quick glance at the ABG if available to ensure the absence of any significant or severe respiratory or metabolic abnormalities. In a trauma ICU, one of the things that we're always paying attention to, especially in patients with severe TBI, is control of ICP. As you can imagine, if someone's having issues with intracranial hypertension, stopping all of their sedatives, analgesics, and having them perform a spontaneous breathing trial is probably not in the patient's best interest. Finally, there may be other reasons why the physician or healthcare team have requested for a patient not to have a measurement, and these should be revisited daily. Over the years, one of the things that we've come to appreciate is the importance of daily interruptions of sedative infusions, previously known as sedation vacation or sedation holidays in mechanically ventilated patients. Kress et al. In a 2000 RCT published in the New England Journal of Medicine found that daily interruption of the infusion of sedative drugs was both safe and resulted in a decreased duration of both mechanical ventilation as well as ICU length of stay. Interestingly, the doses of benzodiazepines used were also different between the control and intervention group. And daily interruptions of sedatives also improved our ability as clinicians to perform daily neurologic examinations, as evidenced by fewer diagnostic tests to assess changes in mental status, and these typically involved CT scans. In the process of determining if a patient is ready for an SBT through the application of this criteria, one of the major advances is our recognition of the importance of tying spontaneous awakening trials, or interruptions in our sedative drips, also known as SATs, to SBTs. Both observational and randomized trials demonstrate that protocols directed at minimizing the use of sedative infusions shorten the weaning process as well. Specifically, approaches intended to avoid oversedation, again, target a RASS of 0. That sounds like a perfect place for your patients to be, by limiting the use of continuous infusions, either through sedation assessment scoring or by daily cessation of sedative infusions, decreased duration of mechanical ventilation, and overall ICU length of stay. Now, several years after that original CRESS study, Gerard, together with Kress, Ely, and co-authors, published the results of a trial that employed a wake up and breathe strategy, also known as the ABC trial, published in The Lancet. In this prospective RCT, patients were randomized to a daily awakening trial, SAT, followed by an SBT versus SBT alone. And patients in the intervention group experienced increased time off of the ventilator, decreased time in a coma-like state, and decreased ICU as well as hospital length of stay. Another interesting finding here was that there was improved survival. It's difficult to really ascertain or attribute that to the specific intervention, but there was improved survival in the intervention group at 1 year. Interestingly, both groups of patients actually progressed to the point of passing an SBT at the same rate, and as such, you might extrapolate that the improved outcomes may have been derived from the fact that patients were both awake and ready for extubation once they passed the SBT. Interestingly, in terms of the number of patients who self-extubated, this was actually statistically significantly higher in the intervention or SAT and SBT group, but the rate of re-intubation was actually similar between the two groups. Now, certain groups have taken the whole protocol of daily interruption of sedation to a whole new level, and in 2010, a group out of Denmark published a randomized controlled trial of no sedation versus daily interruption of sedation, and the impact of that on ventilator-free days. And if you actually look at the study, it's pretty resource and personnel intensive. Essentially, you've got someone sort of with the patient, holding their hand, reassuring them, and pushing PRN IV boluses of analgesics and sedatives PRN. I can tell you that we certainly don't have the bandwidth to perform this sort of patient care where I work, but it is interesting that people are really taking the whole concept of a no sedation or absolute minimal sedation to a whole new level, and this is being associated with improved outcomes. I guess two other key things to point out in patients who were thinking about getting off the ventilator that may contribute to their success are, number one, early and aggressive use of PT and OT, which have been shown in several randomized trials to be associated with improved outcomes, including decreased ventilation days and ICU length of stay among critically ill patients. And the other significant contribution that's been made over the last several years comes from the Society of Critical Care Medicine and the ICU Liberation Bundle, which consists of the A, B, C, D, E, and F of patient care. And I'd refer you to sccm.org. You can also check out the links in our show notes. But really quickly, A stands for Assess, Prevent, and Manage Pain. B refers to both SATs and SBTs, which is what we're discussing now. C is choice of analgesia and sedation. And for those of you who have been in the ICU recently, you may notice more and more use of medications like Precedex or dexmedetomidine, which helps out with the D, delirium, assess, prevent, and manage, together with the CAM ICU assessment. E stands for early mobility and exercise, as we just mentioned. And then, of course, F is family engagement and empowerment. And we'll have a future episode dedicated to breaking down this ICU Liberation Bundle. But having assessed our mechanically ventilated patient and making the determination that they, in fact, are now ready for an SBT, the next assessment we want to perform is, are they tolerating the SBT? Which brings us to the second objective for today's rounds, namely to describe commonly used weaning parameters that may assist us in determining the likelihood of success or failure during a spontaneous breathing trial. Commonly referred to as weaning predictor tests, there are several types of measurements or assessments that we or the RTs can make. And broadly, these measurements can be classified as number one, measurements of oxygenation, ventilation, and gas exchange. And earlier we mentioned the PF ratio. This would also include their PaO2 or PaCO2 on a gas, their oxygen saturations, and in general, these are pretty poor predictors of weaning success, as we typically use oxygenation status as a reason for initiating an SBT. We want to see SATs greater than 90%, for example, and so this may result in test referral bias. Other measurements that may be used include the tidal volume, which we typically like to see around 5 cc's per kg. Other measurements include measurements of the load on the respiratory system, such as minute ventilation, which we typically expect to be in the 5 to 6 liters per minute range, or 1 liter per 10 kilograms. You definitely want to see minute ventilations less than 10 to 15 liters per minute. Perhaps even better than measures of respiratory load are measurements of respiratory muscle capacity, and the classic one here is the MIP, or maximal inspiratory pressure, also sometimes used interchangeably in its place is the NIF, or the negative inspiratory force, and these are really a global assessment of the strength of the inspiratory muscles and can be measured by attaching a manometer to the opening of the endotracheal tube and asking the patient to maximally inspire against an occluded airway. Early studies suggested that a MIP of minus 30 centimeters of water or less was associated with successful weaning, while a MIP of minus 20 centimeters or more was associated with weaning failure. Now, as you can imagine, there are several issues or problems with assessing a MIP or a NIF. Number one, your patient has to be awake, alert, cooperative. Number two, they have to understand what you're asking them to do. And number three, it's not really that helpful in all patients. So my personal practice really is if there's a concern for some sort of neuromuscular disorder, for example, myasthenia, or if a patient has Guillain-Barré, or if a patient has a high cervical spinal cord injury and I'm concerned about diaphragmatic function or the strength of the inspiratory muscles, these are times when I would ask the RTs for a NIF or MIP. It's not something that I ask for universally when I'm trying to assess whether or not a patient is going to tolerate a spontaneous breathing trial. And again, the thing I do want to point out with all these weaning parameters is that none of these parameters are designed to determine whether or not your patient can be successfully extubated and stay extubated. These are all tests that may or may not be employed typically within the first few minutes of transitioning a patient over to a spontaneous breathing trial to really get a sense early on as to whether or not they're going to tolerate that 30 or 120 minute SBT. And the other measurement of respiratory capacity that sometimes gets used is the vital capacity, which is typically 2 to 3 times the tidal volume. We said earlier, tidal volume would be expected to be at least 5 cc's per kg, so a vital capacity should be between 10 to 15 cc's per kg. Similar to the MIP, I kind of think of the vital capacity as assessing the ability of a patient to generate a cough. And so in addition to the MIP and all the other measurements we've talked about, vital capacity is something that sometimes does get used as well. Finally, the other measurement that we do have are the use of integrative indices, and these indices essentially integrate several physiologic mechanisms and were developed in an attempt to improve the accuracy of prediction. And by far, the most commonly used and most talked about integrative index is the Yang and Tobin index, also known simply as the Tobin index, or the Rapid Shallow Breathing Index /RSBI. And this really is the ratio of respiratory frequency to tidal volume. And as I stated, it's the most extensively studied and probably commonly used weaning predictor. So the analogy I make when I talk about the RSBI or RSBI is just thinking about cross-country or long-distance runners. And for me personally, I'm not much of a runner, but if I was to go out this morning and try to run a 5 or a 10 mile a run, I'm pretty sure that about half a mile into it, I would be very tachypnic and taking in very shallow breaths. Now, compare that to an actual athlete who's trained to do these sorts of marathons, and probably by the 10th or 12th mile, they would probably still have a low respiratory rate and a very high tidal volume. So getting back to our mechanically ventilated patients, you can imagine that those patients who are not tachypnic and drawing in large tidal volumes would have a low RSBI score, and you would think that this might be predictive of extubation success, but in fact it's not. If you actually look at the data and the evidence, it would actually suggest that a negative RSBI, or a score greater than 105 breaths per minute per liter, is actually better at identifying patients who will fail weaning than a positive RSBI is at identifying patients who can be successfully weaned. Personally, I like to get a sense as to what the patient's RSBI is when they're immediately placed on an SBT, and provided that they're tolerating their SBT. Again, this is based on a collective assessment of a number of symptoms as well as signs from neurologic to pulmonary to cardiovascular, in addition to some of these objective indices. But if they're tolerating it, then I'd probably come back in 15, 20, or even 30 minutes and reassess. And I kind of like to use trends in the RSBI as well as other objective measurements to get a sense as to how patients are doing. So again, just to reiterate, the RSBI has not been shown to decrease duration of weaning or mechanical ventilation. And in general, we want to look at several indices to determine how successful our patients might be. Again, this may have been more important or relevant when we weaned patients. In general, these days, if patients meet the criteria for an SBT, they go onto an SBT, they get a quick assessment, and in 30 minutes or 120 minutes, we're going to make that decision: extubate, yes or no. So moving along to objective 3, in terms of the type of spontaneous breathing trial or SBT, we're primarily focus our discussion on a classic and highly cited paper by Esteban and the Spanish Lung Failure Collaborative Group that was published in the New England Journal of Medicine in 1995, titled "A Comparison of 4 Methods of Weaning Patients from Mechanical Ventilation." And in this prospective randomized study involving 546 mixed medical surgical patients across 14 hospitals, approximately 25% of patients were designated as difficult to wean and randomly assigned to one of 4 weaning strategies. Number 1, progressive decreases in the number of ventilator-assisted breaths during intermittent mandatory ventilation. Number 2, progressive decreases in the level of pressure support during pressure support ventilation. Number 3, intermittent trials of spontaneous breathing conducted several times a day via either a T-piece or CPAP. And finally, once daily trial of spontaneous breathing via a T-piece. And weaning was considered successful if extubation was achieved within the 14-day period and reintubation was not required within 48 hours of extubation. The study had 2 major findings. Number 1, in a select group of patients who were difficult to wean from the vent, the rate of successful weaning depended on the technique employed, and a once daily trial of spontaneous breathing led to extubation about 3 times more quickly than intermittent mandatory ventilation and 2 times as quickly as pressure support ventilation. Now, there was no significant difference in the rate of success between a once-daily trial and multiple daily trials of spontaneous breathing, or between intermittent mandatory ventilation and pressure support. Second, ventilator support was discontinued without any special technique in 2/3 of an unselected group of patients, and only a small proportion, 15%, required reintubation within 48 hours. Now, in terms of key take-home points, these days we're much less likely to perform a T-piece trial, and we simply use pressure support ventilation with a minimal setting somewhere between 5 to 10 centimeters of water, mainly to overcome or counteract the resistance of the endotracheal tube and the ventilator circuit. Although there are those that might argue that this level of support is probably clinically irrelevant or negligible. With that said, the most recent 2017 clinical practice guidelines published by the American College of Chest Physicians in conjunction with the American Thoracic Society when it came to liberation from mechanical ventilation in critically ill adults, conditionally recommend that for acutely hospitalized patients ventilated for more than 24 hours, the initial SBT should be conducted with inspiratory pressure augmentation, 5 to 8 centimeters of water, rather than without, i.e. T-piece or CPAP. And the results of these guidelines were further reinforced by a 2019 RCT published in JAMA, in which the study authors compared the effect of pressure support for 30 minutes versus a T-piece trial for 2 hours on extubation or success of spontaneous breathing trials in mechanically ventilated patients. And in this study, the study authors identified that patients who underwent a half-hour pressure support ventilation SBT with 7 centimeters of water was equally effective in recognizing successfully extubated patients as a 120-minute trial. Again, when it comes to T-piece trials, I'm really not a big fan. There might be a select group of patients, maybe patients in whom I suspect a flailed chest or significant chest wall paradoxical abnormalities. But in general, I really am not a fan of this idea of just breathing through this polyvinyl chloride straw, and feel that depending on what type of ventilator you have, either automatic tube compensation and more simply just the application of pressure support really is the way to go when you're assessing someone during a spontaneous breathing trial. Now, in terms of the optimal duration of an SBT, this typically ranges, as we've already discussed, anywhere from between 30 minutes to 120 minutes or 2 hours. And in general, an initial SBT of 30 minutes in duration is considered sufficient to determine whether the ventilator can be safely discontinued, and a prolonged SBT doesn't appear to be superior to a shorter SBT. And that was identified in a multi-center trial that randomly assigned 526 patients receiving ventilation to undergo SBTs using a T-piece for either 30 or 120 minutes, and the rates of weaning failure and reintubation were virtually identical in both groups. And so if 30 minutes is an adequate test and provides you with the same accuracy of data as a trial that's 4 times as long, why not just stick with the 30-minute trial, assess your patient, and if they pass, then we're going to move on to the final question or the fourth objective. And here we're going to discuss the considerations that we want to address prior to actual removal of the artificial airway. So at the beginning of rounds, we discussed the basic approach to figuring out if our patients can be extubated. And the first question we asked was, can my patient breathe on their own without the ventilator? And we went through the readiness assessment criteria as well as weaning criteria that may potentially predict success of the SBT and how we perform an SBT. The second major question was, can my patient breathe without the endotracheal tube? And so for the remainder of rounds, we're going to focus in on this question. And there's a few important points to bring up when it comes to determining can we remove the artificial airway or endotracheal tube. Now, starting from the top and making our way down, the first thing we want to do is assess airway protection. And this really is the ability to guard against aspiration during spontaneous breathing. And from a neurologic status or mental standpoint, we want to make sure that our patients are ideally extubated awake, alert, and able to follow commands and participate in their care. So if we need them to cough, they're able to do so in order to help with airway management and secretion clearance. Cough strength and secretion clearance, these are things that we definitely want to assess with the help of our RTs and RNs. And as we alluded to at the beginning of the episode, we want to make sure that we're getting multidisciplinary input at all stages of determining readiness for extubation. And when it comes to secretions, these can be measured quantitatively at the bedside, but also asking about the nature of secretions. Are they thick or thin? What color are they? And how often are we having to suction are important. And I think the key thing here is, for me, there's no better way to clear secretions than to cough them up. So just because someone is having thick, purulent secretions, that's not a contraindication to extubation unless the cough is borderline or weak. The other important thing we want to assess for is the risk for post-extubation stridor, and we'll talk about this in more detail in a future episode, but certainly there are going to be certain patient populations in whom we are concerned that upon removal of the ET tube, there is the potential for vocal cord edema, whether this is related to details surrounding their initial intubation, particularly if there were multiple attempts, or if it was a difficult intubation, or related to laryngeal injury, the duration of endotracheal tube insertion, or potentially and rarely tracheal stenosis or lesions. So in patients who are considered at high risk, these are patients in whom we would probably want to perform a cuff leak test. And again, we'll talk about that in a future episode. And in patients in whom we're concerned are at high risk for post-extubation stridor, these are patients in whom we would consider initiation of corticosteroids. Again, this is typically limited only to those patients who are deemed to be at high risk, and the dose as well as duration of steroid replacement or steroid therapy really does vary, and there are several systematic reviews demonstrating that this is effective for decreasing post-extubation stridor in the appropriate patient population. Now, as we move further down, obviously we want to think about considerations regarding the cardiovascular and pulmonary systems. And when it comes to the cardiovascular system, the one thing that we do need to emphasize and that I always stress is that in patients who have poor LV function, ventilators are great. So bad LV, positive pressure ventilation, great. And we see this all the time when patients have acute cardiogenic pulmonary edema and you put them on some BiPAP that helps to decrease the afterload, thereby augmenting cardiac function. But the opposite applies when you're extubating someone. So when you're taking someone with a bad LV or low EF or poor LV function and you remove positive pressure ventilation, they don't like that. All right. Poor LV likes positive pressure ventilation. Patients with a bad RV don't like positive pressure ventilation and in general like coming off of positive pressure ventilation. So I bring this up now because when we are considering removing positive pressure ventilation, when we're at that point where we're thinking, should we pull this ET tube out or not, think about those patients who are at risk for cardiac dysfunction and make sure that they're medically optimized. Again, you're going to be removing a factor that's been helping to decrease the afterload. So in patients with a reduced EF, have they been optimally diuresed? Have they been started on an ACE or an ARB to help with afterload reduction? And are they on beta blockade, typically in these scenarios carvedilol, in an effort to decrease heart rate and improve overall cardiac outcomes? And so bundled with the question of removing the ET tube from the standpoint of a cardiovascular standpoint, you always want to ask yourselves, is this patient so high risk that we should consider extubating directly to BiPAP or non-invasive ventilation? Finally, a couple of other considerations that do come up are, number one, what's the potential difficulty in terms of reintubation? And that kind of gets back to when we were talking about post-extubation stridor, but we certainly want to risk stratify particular patients in terms of the risk for reintubation or difficulty of reintubation. And then the other issue that does come up is there an ideal time to extubate patients? And our protocol here is to typically do it first thing in the morning. But that's not to say that we can't extubate patients at any time of day or night. A lot of this is going to be directed by what sort of help and resources are immediately available, as well as the comfort level of the RTs, RNs, and ICU staff, as well as faculty. So, just to summarize, the decision to discontinue mechanical ventilation is something that we want to assess for all of our ventilated patients on a daily basis, as the ultimate goal of mechanical ventilation is to no longer need mechanical ventilation. When it comes to assessing patients for readiness to perform an SBT and examining weaning predictors that might potentially identify those patients that will succeed, we want to use a protocolized approach. And in general, this is something that we do not want to leave to physicians. So an RT or RN-driven protocol, which focuses on partnering SATs to SBTs together with early PT/OT and minimization of analgesia, sedation, and targeting things like delirium. Identification as well as early and aggressive treatment are critical. And these days, most patients that go on to an SBT aren't weaned to an SBT. In general, patients are placed on pressure support ventilation in an effort to overcome some of the resistive work that needs to be overcome in the process of breathing spontaneously. And in general, 30-minute SBT trials are just as effective as 120-minute trials in determining readiness for extubation. Finally, when it comes to that decision to remove the endotracheal tube, be systematic and organized, thinking anatomically. Key things to consider here really are neurologic status, cardiovascular as well as pulmonary status, and concerns with post-extubation stridor or difficulty with potential re-intubation in the case of a failed extubation. Well, that wraps it up for today's rounds. I want to thank you for joining me this week and every week for our trauma ICU rounds. If you like what you're hearing, please leave us a positive comment and a 5-star rating on iTunes. Also, make sure that you visit the website, www.traumaICUrounds.com. You can sign up for our newsletter there and also leave us a question, comment, or suggestion for future rounds. Until next time, keep reading, take care of yourself, take care of one another, and we'll talk soon. Peace.